Welcome you all dear students. In this module, I, Dr. Shushma Bibi, will be talking with you about carbohydrate metabolic disorders. As we all know, carbohydrates accounts for a major portion of the human diet and are metabolized into three principal monosaccharides: galactose, fructose and glucose. The failure to effectively use this sugar accounts for the various forms of carbohydrate metabolism disorders. The most common disorders are acquired or secondary dearrangements in carbohydrate metabolism, such as diabetic ketoacidosis, hyperosmolar coma, and hypoglycemia. All affect the central nervous system, as well as various forms and variants of peripheral nerve disease are commonly seen in diabetes. The other disorders of carbohydrate metabolism are the inborn errors of metabolism, that is, genetic defects that affect the catabolism and anabolism of carbohydrates. By the end of this episode, we will be understanding about disorders of carbohydrate metabolism by understanding about pathophysiology of inherited disorders, types of carbohydrate metabolic disorders. What is the pathophysiology of inherited disorders? Many of the clinical features of the inherited disorders of carbohydrate metabolism are caused by the following: lack of glucose for the metabolism of brain, muscle, liver or kidney, inability to break down glucose to pyruvate, inability to oxidize pyruvate fully in the Krebs cycle. Some features of the inherited disease are due to excessive storage of abnormal substrates or to normal substrates that cell cannot degrade normally because they lack a specific enzymic activity. In some disease, abnormal metabolites block the normal function of the pathway or related pathways. Defects of the enzymes of the pentose shunt interfere with the normal production of nucleic acids, which are needed by cells as second messengers and as coenzymes of intermediary metabolism, as well as components of RNA and DNA. Galactose accumulates in the lens of the eye in galactokinase deficiencies. So now let's learn about some of the types of inborn errors of carbohydrate metabolism: galactosaemia, glycogen storage disease, pyruvate carboxylase deficiencies, fructose 1,6 biphosphatase deficiency, hereditary fructose intolerance, glucose 6-phosphate dehydrogenase deficiencies. Now first let's know about galactosaemia. Lactose from milk is hydrolyzed by intestinal lactase to produce glucose and galactose. There are three inborn errors of galactose metabolism: galactokinase deficiencies, galactose 1-phosphate uridynyl transferase deficiency, uridine diphosphate galactose 4 epimerase deficiencies. The pyrophosphorylase pathway is an alternative route for production of UDP galactose. The generation of galactose 1-phosphate by this pathway explains why galactose 1-phosphate can still be synthesized in patients with galactosaemia who are on strict dietary galactose restriction. So what is classical galactosaemia? This is the disorder due to galactose 1-phosphate uridyl transferase deficiency. There is an accumulation of galactose 1-phosphate and galactose and secondary formation of galactitol. It's a typical presence by the end of the first week of life with poor feeding, vomiting, lethargy, jaundice, hepatomegaly, neonatal cataracts, and renal tubular disease, and is often associated with E. coli septicemia. Biochemically, there is hyperbilirubinemia, raised alanine aminotransferase. Generally, elevated plasma and urine amino acids, albuminuria, glycosuria, and galactosuria. If galactose is excluded from the diet, then life-threatening illness usually resolves quickly. Long-term complications, example, low IQ, growth delay, ovarian dysfunction still occurs despite early diagnosis and treatment possible. Due to endogenesis galactose production, partial enzyme deficiencies occur and several variant alleles exist. That is, Dorette, usually benign, identified on newborn screening, especially in some European countries and USA. Galactokinase deficiencies. This is a rare disorder where there is an inability to phosphorylate galactose and galactose and galactitol are excreted in urine. Neonatal cataracts occur often bilateral due to the accumulation of galactitol in the lens. There is a positive urine reducing substance due to galactose in urine, usually with a negative clinstics. Diagnosis is by measurement of galactokinase activity in the red cells. Treatment is with galactose-free diet. The cataracts are reversible if milk excluded in first few weeks of life. So now let's understand about UDP galactose 4 epimerase deficiencies. Mild form of UDP galactose 4 epimerase deficiencies occur due to reduced protein stability and more pronounced in cells with long lifespan, example erythrocytes. The growth and development appears to be normal in an individual affected. Severe form of UDP galactose 4 epimerase deficiencies is very rare. This is a similar presentations to classical galactosemia. There will be accumulation of UDP galactose and galactose 1 phosphate in this condition. The deficiencies is identified using Butler test confirmed by increased normal and red cell galactose 1 phosphate. The definitive test is assay of UDP galactose 4 epimerase activity in erythrocytes. What is glycogen storage disease? Glucose is stored in the form of glycogen, mainly in liver and muscles. Glycogen is made up of straight chains of glucose residues with alpha-1,4 linkages, branched at intervals with alpha-1,6 linkages. Glycogen metabolism is highly regulated by several amplifying reactions, cascades. Adrenaline and glucagon stimulate glycogen breakdown. Glycogen synthesis is increased by insulin. In glycogen storage disease, liver and muscles are the foremost affected tissues. Glycogen storage disease 1, the one of the form of disease which accounts for approximately 25% of glycogen storage disease cases. Glucose 6-phosphate deficiencies is a defect in the release of glucose from glucose 6-phosphate and affects both glycogenolysis and gluconeogenesis. It presents with hepatomegaly, short stature and tubercle obesity. Biochemically, there is hypoglycemia, lactic acidemia, hyperuremia and hyperlipidemia. Histological analysis shows excess of fat and glycogen in hepatocytes. GST1 is a defect in transporter protein and as the above features plus neutropenia. recurrent bacterial infections, and inflammatory bowel disease. The diagnosis is nowadays confirmed by DNA analysis in the majority of patients. It is also possible to measure the activity of glucose 6-phosphatase and the transporter protein function in fresh liver biopsy with comparison of fresh and frozen results to distinguish type 1 form of 1b, pyruvate carboxylase deficiency. This condition is presented with lactic acidosis neurological dysfunctions, including seizures, hypotonia, coma. Its defect in the first step of gluconeogenesis, which is the production of oxalol acetate from pyruvate. In addition to the effect of gluconeogenesis, lack of oxaloacetate affects the function of the Krebs cycle and the synthesis of pyruvate. In the acute neonatal form of lactic acidosis is severe, there is moderately raised plasma ammonia. Citrulline and ketones fasting results in hypoglycemia with a worsening lactic acidosis. The diagnosis can be confirmed by an assay of pyruvate carboxylase activity in cultured skin fibroblasts. Patients rarely survive more than 3 months in the severe form. Now we will study about what is fructose 1,6 biphosphatase deficiency. The defect leads to impaired gluconeogenesis and accumulation of precursor of gluconeogenesis, lactate, pyruvate, alanine and ketones. The only glucose source is dietary or via glycogenolysis. The latter may be a problem in neonates as they usually have low glycogen stores. Acute episodes may be precipitated by fasting or infection. Diagnosis is by assay of fructose 1,6 biphosphatase activity in leukocytes or liver homogenate. However, there are some reports of normal leukocytes activity in an individuals with deficient liver activity. Treatment involves correction of the acidosis and hypoglycemia and the avoidance of fasting. Once diagnosed, growth and development are usually normal. What is hereditary fructose intolerance? Fructose is a monosaccharide found in fruit, honey and many vegetables. The disaccharide sucrose composed of glucose and fructose is found mainly in foods. Sorbitol can be converted into fructose by the liver. Hereditary fructose intolerance, a defect in fructose metabolism, only presents after ingestion of foods containing fructose, sucrose or sorbitol. When an infant with hereditary fructose intolerance is weaned, they suffer from nausea, vomiting, gastrointestinal discomfort and lethargy. They are at risk of liver and kidney failure and death if fructose is not withdrawn. Affected individuals may reach adulthood undiagnosed due to development of an aversion to fructose containing foods. Around 50% of adults with hereditary fructose infants have no dental caries. So occasionally the diagnosis has been made by dentists. Biochemical features include hypoglycemia, hypophosphatemia, elevated plasma lactate, positive urine reducing substance, hyperuricemia and a generalized aminoaciduria. Now we will understand about glucose 6-phosphate dehydrogenase deficiency. This is an X-linked defect in the first irreversible step of the pentose phosphate pathway. A decrease in NADPH production makes red blood cells membranes vulnerable to oxidative stress, leading to hemolysis. The most common manifestations are early neonatal, unconjugated jaundice and acute hemolytic anemia. However, most individuals with deficiency are clinically asymptomatic. The hemolytic crises are usually in response to an exogenous trigger such as certain drugs or an infection. Female heterozygotes may have symptoms, but severity varies due to non-random X chromosomes inactivations. Diabetes mellitus. Diabetes mellitus is a group of metabolic disease in which a person has high blood sugar, either because the pancreas does not produce enough insulin or because cells do not respond to the insulin that is produced. This high blood sugar produces the classical symptoms of polyuria and polyphagia and polydipsia. There are three main types of diabetes mellitus. Type 1 diabetes mellitus results from the body's failure to produce insulin and currently require the person to inject insulin or wear an insulin pump. This form was previously referred to as insulin-dependent diabetes or juvenile diabetes. Type 2 diabetes results from insulin resistance, a condition in which cells fail to use insulin properly, sometimes combined with an absolute insulin deficiency. This form was previously referred to as non-insulin dependent diabetes or adult onset diabetes. The third main form, gestational diabetes, occurs when a pregnant woman without a previous diagnosis of diabetes develop a high blood glucose level. It may precede development of type 2 diabetes mellitus. Other forms of diabetes mellitus include congenital diabetes, which is due to genetic defects of insulin secretion, cystic fibrosis related diabetes, steroid diabetes induced by high dose of glucocorticoids, and several forms of monogenic diabetes. Untreated diabetes may cause many complications. Acute complications include diabetic ketoacidosis and non-ketotic hyperosmolar coma. Serious long-term complications include cardiovascular disease, chronic renal failure, and diabetic retinopathy. Adequate treatment of diabetes is thus important, as well as blood pressure control and lifestyle factors such as stopping smoking and maintaining a healthy body weight. Classification of diabetes mellitus up to now remains clinical. Main types: insulin-dependent diabetes mellitus and insulin-independent diabetes mellitus. These two diabetes types affect the majority of patients. Insulin-dependent diabetes mellitus. It arises as a result of absolute insulin insufficiency. It is described by insulinopenia and by inclination to ketoacidosis. This diabetes occurs more frequently in children and young people. Insulin is needed for sustenance of patient's life. Attached to its absence, ketoacidic coma develops. Insulin-dependent diabetes mellitus has genetic base. Inclination to diabetes of this type is conditioned by some genes of major histocompatibility complex. Pathogenesis of insulin-dependent diabetes mellitus. People with diabetes mellitus form a low resistibility of beta cells, which gets lightly collapsed and is very difficult to restore. High readiness to destructions by limited capacity for regenerations. The system of HLA genes are inherited from generation to generation. Therefore, inclination of beta cells to destruction also is inherited from generation to generation. However, general amount of beta cells is attached to birth identically in patients and healthy. Insulin-dependent diabetes is the result of equilibrium violation between destruction of beta cells and their regenerations. Both processes, increase of destruction and limitation of regenerations, are genetically conditioned. Depending upon affection, mechanisms of beta cells, there are two forms of insulin-dependent diabetes mellitus, that is autoimmune and virus-inductive. Autoimmune insulin-dependent diabetes arises in persons with genome DR3. It is associated with other autoimmune endocrinopathies, for example, with illness of thyroid glands. This diabetes type develops in any age, more frequently in women. Autoimmune is diabetes described by presence in blood of patients autoantibodies against of Langerhans islets. Virus-induced insulin-dependent diabetes mellitus. It is binded with genome DR4 and different form of autoimmune on mechanisms of development. In this case, there are no autoantibodies against islets of pancreas. It certainly can appear in blood but rapidly disappear. They do not perform essentially role of pathogenesis of illness. Development of this diabetes type frequently proceed from viral infections, epidemic parotitis, German measles, and viral hepatitis. Viral-induced diabetes arises early before 30 years of life. It is identically widespread and among males, both among women. Insulin-independent diabetes mellitus. This diabetes type principles differs from the first. Patients as a rule don't need to exogenic insulin. Metabolic disorders attached to this diabetes are minimal. Diet therapy and pre-oral glucose decreasing medicines are sufficiently for their compensations. Only in stress conditions patients use insulin. Illness can course for years without hyperglycemia. Sometimes it is disclosed in age more 40 years. There are three factors group which play decisive role in forming of this diabetes type. Here are the genetic factors, functional disturbance of beta cells and insulin resistance. Genetic factors determines hereditary liability to disease. Specific genetic marker is not found. It's known only that inclination of insulin-independent diabetes is not coupled with major complex of histocompatibility. Functions of beta cells of patients with insulin-independent diabetes is violated. Among of them is diminished. Attached to loading by glucose, they do not multiply insulin secretions in necessary amount. Diabetes connects these violations with amyloidosis of Langerhans islets. Insulin resistance arises or an genetic base or as a result of influence of external factors. Biological insulin actions is mediated over receptors. They are localized on cells targets membranes. Interactions of insulin and receptors is followed with changes of physical state of cells target membranes. As a result of this, transport system is activated which carries glucose over cellular membrane. Transmembranes moving of glucose is provided by protein transmitters. Clinical features of diabetes: hyperglycemia, glucosuria and polyuria. Hyperglycemia is connected foremost with lowering of glucose utilization by muscular and fatty tissues. Lowering of glucose utilization as membrogenic nature. In case of insulinopenia and in case of insulin resistance, interactions of insulin and receptors is damaged. Therefore, protein transporters of glucose are not included in membranes of cells targets. This limits glucose penetration in cells. Glucosuria. In healthy man practically has not glucose in urine. It is excreted in amount not more than 1 gram. Attached to sugar diabetes, amount of excreted glucose increases repeatedly. If glucose concentration in blood and primarily urine does not exceed 9 millimolar per liter, epithelium of canaliculi reabsorbed it. This maximum concentration is called nephritic threshold. If a glucose concentration exceeds a nephritic threshold, part of glucose goes in secondary urine. Polyuria. Glucose is osmotic active substance. Increasing of its concentration in primary urine raises osmotic pressure. Water is excreted from organisms together with glucose. Patients excrete 3 to 4 liters of urine per day, sometimes still 10 liters. The very frequent diabetes complications are following: ketoacidosis, macrogenopathy, microgenopathy, and neuropathy. Ketoacidosis. In healthy peoples, synthesis of ketone bodies in liver is strictly controlled. Main regulatory mechanisms is excess limitations of fatty acids in mitochondria of hepatocytes. Overweight permissible concentration limit ketone bodies in blood is approximately 0.1 millimolar per liter. In case of exceeding this level, regulatory mechanisms are stated. Foremost, ketone bodies but specific receptors back up on membrane beta cells of Langerhans islets. Insulin excretion in blood increases. Insulin stimulates the resynthesis of fat acids. First stage of resynthesis is derivation. If malonyl CoA, surplus amount of malonyl CoA oppresses penetration of fatty acids in mitochondria. Synthesis of ketone bodies slows down. Microangiopathy develops in shallow vessels, arteries, veins, capillaries. Two processes form their pathogenic base: thickening of basal membrane and reproduction of endothelium. Direct cause of microangiopathy is hypoglycemia and synthesis of glycoproteins in basal membranes. There are two main clinical forms: microangiopathy, diabetic retinopathy, and diabetic nephropathy. Nephropathy manifests by violation of nerves functions: sensible, motor, vegetative. Essence of this decreases is demyelinations of nerve fibers, decrease of exoplasmatic flow. Now let's sum up of the content. Carbohydrate disorders may result from deficiencies of the enzymes that split sugars to their smallest parts in the small intestine, or from a deficiency of compound that carries glucose and galactose from the small intestine may be similar. Whatever the cause and include watery diarrhea, gas, and bloating. Abdominal cramping may occur, and if diarrhea persists, dehydrations and acidosis may be severe. There can be organ involvement, such as the liver, where certain enzyme activity and metabolic pathways are centered. Treatment is mainly can be nutrition management, which involves substrate restriction such as lactose, galactose restriction in someone with galactosaemia. The ketogenic diet is commonly used as a nutrition management. GLUT1 functions can effectively take place by glucose uptake in the absence of insulin.